Hello everyone and welcome to my YouTube channel. Today's talk will be on persistent pulmonary hypertension of the newborn. So just a quick overview. We'll be going over a recap of the fetal circulation definition, and then definition, epidemiology, pathophysiology of persistent pulmonary hypertension of the newborn. Then we're going to how to diagnose it and management. So fetal circulation, we know that in the fetal circulation, gaseous exchange occurs primarily in the placenta, and the pulmonary and systemic circuits operate in parallel, having both the right and the left ventricles ejecting blood into the aorta. At this stage, the right ventricle is dominant and shunts blood from the right to the left through the foramen ovale and the ductus arteriosus, and the blood flow bypasses the lung. Because the lung is fluid-filled and has a higher pulmonary vascular resistance, and the systemic vascular resistance is low, deoxygenated blood returning from your superior and inferior vena cava. So it's basically a mixing of blood in the right side of the heart, and that's shunted to the left by the foramen ovale and the ductus arteriosus, and you have mixed blood ejected into the aorta. So transition from fetal life, there's an increase at the stage your placenta, when the umbilical cord is clamped, essentially the placenta is removed, and this causes an increase in systemic vascular resistance, and at the same time expansion of the lung and clearance of the fetal lung fluid causes a decrease in pulmonary vascular resistance and results in gaseous exchange occurring in the lung. And the increase in pulmonary blood flow as a result of the above causes closure of your right to left shunt of fetal circulation. So your ductus arteriosus will close physiologically, and so will your foramen ovale. Any condition that interferes with the decrease in the pulmonary vascular resistance to systemic vascular resistance ratio causes persistence of the fetal circulation, which results in persistent pulmonary hypertension of the newborn. The diagram on the left, so A, again is illustrating the fetal circulation, and the diagram on the right demonstrates the normal postnatal circulation or post-birth circulation. So blood returns to the right heart from the body, deoxygenated blood, and because your foramen ovale is closed, your blood will move from the right atrium to the left ventricle, into your pulmonary trunk, into the lungs, because now we have pulmonary blood flow in the lungs, and you don't have shunting of blood from the left to the right via the ductus arteriosus because it closes physiologically. So your aorta should eject oxygenated blood to the rest of the body. So in persistent pulmonary hypertension of the newborn, this is characterized by an increase in pulmonary vascular resistance, and you have extrapulmonary shunting of blood from the right to the left through the patent foramen ovale and the ductus arteriosus. This consequently causes hypoperfusion of the lungs and severe hypoxemia that may not respond to conventional ventilation. So this is again an illustration of, on the left, what normal circulation should look like after birth, and on the right is persistence of fetal circulation with mixing of blood again through the patent foramen ovale and the patent ductus arteriosus, and mixed blood being ejected into the aorta. So the prevalence of PPHN has been estimated at 1.9 per 1,000 live births, and it occurs primarily in term or late preterm infants who are at a gestational age of more than 34 weeks or more. The prevalence is also increased in extremely preterm infants with a gestational age of less than 28 weeks, and the risk is seeming to increase with decreasing gestational age. A population-based study done in California of 385 infants born at a gestational age of more than 34 weeks without congenital heart disease identified the following risk factors for PPHN. So a gestational age of 34 to to 37 weeks, so basically late preterm infants. Black maternal race. Infants who are either large or small for gestational age, and mothers with diabetes, obesity, and advanced maternal age. The pathogenesis, so we observe 3 types of abnormalities of the pulmonary vasculature that underlie the disorder: underdevelopment, maldevelopment, and maladaptation. And evidence suggests that injury to the developing pulmonary circulation may disrupt vascular endothelial growth factor signaling, which can contribute to these abnormalities. So in underdevelopment, the diameter of the pulmonary vascular lumen is reduced, which then results in fixed elevation of the pulmonary vascular resistance. Conditions associated with underdevelopment, this basically occurs in pulmonary hyperplasia, which the conditions you see with this are your congenital diaphragmatic hernia, congenital pulmonary cystic adenomatoid malformation, renal agenesis, oligohydramnios accompanying obstructive uropathy, and fetal growth restriction. In maldevelopment of the pulmonary vasculature, this is associated with conditions such as postterm delivery, meconium staining, and meconium aspiration syndrome. And in these disorders, the pulmonary vasculature responds poorly to stimuli that usually result in a decrease in pulmonary vascular resistance. And then you have disorders producing excessive perfusion of the fetal lung, which may also predispose to vascular maldevelopment, but not necessarily to PPHN. And this can occur in premature closure of the ductus arteriosus caused by NSAID use in pregnancy, high placental vascular resistance, so basically preeclampsia, and then also total anomalous pulmonary venous drainage. So in maldevelopment, the pulmonary vascular bed is normally developed. However, adverse perinatal conditions cause active vasoconstriction and interfere with normal postnatal fall in pulmonary vascular resistance. And these conditions are more likely to cause PPHN, so that you have perinatal asphyxia, pulmonary parenchymal diseases, and then bacterial infections such as group B streptococcus. This diagram illustrates the different pathological abnormalities in the pulmonary vasculature and the causative conditions that may result in these abnormalities. So basically, you can have secondary causes of PPHN, such as the congenital diaphragmatic hernia, as we've mentioned before, which all cause maladaptation of your pulmonary vasculature, sepsis and pneumonia, pulmonary hyperplasia, meconium aspiration syndrome, perinatal asphyxia, and pulmonary stenosis. Clinically, most neonatal present with PPHN will present within the first 24 hours of life with signs of respiratory disease. So then you have to sift out what the cause is. Examination findings will include cyanosis, distress, and hypoxemia. Cardiovascular examination will findings are prominent precordial impulse, split S2, and a pansyscardic murmur of tricuspid regurgitation at the left lower sternal border. So in terms of investigating this respiratory distress, on pulse oximetry, you find differential stats of more than 10% between the pre and post ductal oxygen saturation, and that this is due to the left to right shunt through the patent ductus arteriosus. And if there's no gradient difference, then you should consider a patent foramen ovale to be present. Blood gas will show a low pH of less than 100 millimeters of mercury in patients who already are receiving 100% FiO2. And in patients who are ventilated, they'll have an oxygenation index of more than 25. And chest X-ray may be normal or have associated pulmonary conditions such as congenital diaphragmatic hernia, parenchymal disease and pneumonia, and the cardiothoracic ratio may be normal or enlarged, with pulmonary blood flow being normal or reduced. Looks more like a meconium aspiration X-ray, with perihylar opacities in the lungs, left more than right, and the lungs in this image are actually hyperinflated. But a meconium aspiration can also be a cause of PPHN. Echocardiography is the gold standard for definitive diagnosis of PPHN, and it's important because we have to exclude structural heart disease before we can confirm a diagnosis of PPHN. Echo findings will include normal structural cardiac anatomy with evidence of pulmonary hypertension. Doppler studies on echo will demonstrate left to right shunting through the patent ductus arteriosus and or foramen ovale, and you have a tricuspid regurgitation jet, and your right ventricular systolic pressures are increased as a result of increased pulmonary vascular resistance. Your left atrium, you see that there's a painful foramen ovale, which causes shunting of deoxygenated blood from the right to the left. You also see that from the blood is shunted from the right to the left, between the pulmonary trunk and the aorta. And the increased pulmonary vascular resistance from the pulmonary trunk will also cause an increase in right ventricular pressures, and we see this demonstration, or this diagram demonstrates interventricular dependence as a result of increased pulmonary vascular resistance and right ventricular pressures. So we also use the echo to grade severity of PPHN, and we do this by comparison of right ventricular pressure with the systemic blood pressure. So in mild to moderate PPHN, estimated right ventricular pressure is between half to 3/4 of the systemic blood pressure. In moderate to severe PPHN, the estimated right ventricular pressure is more than 3/4 of systemic blood pressure, but still below systemic blood pressure. And in severe PPHN, you find right ventricular pressures that are greater than systemic blood pressure. And also evidence of right ventricular dysfunction is suggestive of severe PPHN. So now we are going to get into the management of PPHN, which is quite an extensive topic. So management includes general supportive cardiorespiratory care and ICU, providing supplemental oxygen, mechanical ventilation, fluids to correct acidosis, and inotropic agents for circulatory support. And important is minimal handling. And these management strategies are aimed at maintaining adequate systemic pulmonary blood pressure and decreasing pulmonary vascular resistance, as well as ensuring oxygen release to the tissues and minimizing barotrauma induced by high levels of inspired oxygen and high ventilated pressure settings. So in terms of oxygen, we know that oxygen is a pulmonary vasodilator. So we start off with an initial oxygen concentration of 100%, and this should be adjusted to maintain preductal saturations of 90 to 94%. We need to avoid hyperoxia or hypoxia, and it's important to maintain hemoglobin concentration of 15 to 16 grams per deciliter and optimizing circulatory function if we can't maintain stats above 90%. And if these measures don't result in adequate oxygenation, so basically if your oxygenation index on the vent is greater than 25, then more direct invasive measures are required. And we'll get into oxygenation index later. Ventilation strategies. We know that hypercarbia and acidosis increase pulmonary vascular resistance, and so the ventilation strategy we use needs to target a partial pressure of carbon dioxide of 40 to 50 millimeters of mercury to minimize lung injury associated with high tidal volumes. And we aim for, as I said before, sats of 19 to 94%, and the pH on our blood gas must be greater than 7.25, so basically to avoid acidosis. And the mode of ventilation will depend upon the presence or absence of pulmonary parenchymal disease and infant response to treatment. In PPHN with no associated lung disease, so basically primary PPHN, hypoxemia is caused purely by a right to left shunting rather than a ventilation perfusion mismatch. So the ventilator strategy doesn't necessarily help, and we need to aim for strategies that will elevate the mean airway pressure. Aiming for strategies that will elevate mean airway pressure may actually impede cardiac output and increase pulmonary vascular resistance. So therefore, our goal in these patients is to decrease the mean airway pressure by decreasing your driving pressures and having shorter inspiratory times, or opting for volume control ventilation, which always have to maintain adequate PEEP. And then basically in secondary PPHN, so in patients with associated lung disease, atelectasis and the resulting maldistribution of ventilation, so basically ventilation perfusion mismatch, may exacerbate high pulmonary vascular resistance. So we use PEEP to recruit atelectic segments and to maintain functional residual capacity and ensure appropriate oxygenation and ventilation. A patient-triggered mode may improve synchrony with the vent. And then if we need to change to high frequency oscillator ventilation if the driving pressures we're using to ventilate the patients are more than 25 to 28 centimeters of water, if your tidal volumes are greater than 6 moles per kilogram. If you're using these settings to maintain a PaO2 of less than 60 millimeters of mercury on conventional ventilation. In terms of sedation, we know that pain and agitation can cause catecholamine release, which can result in increased pulmonary vascular resistance and increased right to left shunting. Agitation may result in ventilator asynchrony as well, which can worsen hypoxemia. So we need to add an opioid analgesic. And our options are morphine sulfate and fentanyl. Morphine sulfate functioning more as an analgesic agent, and fentanyl for both sedation and analgesia. So for circulatory support in patients with PPHN, a decreased systemic blood pressure exacerbates the right to left shunt. So we need to aim for systemic blood pressure targets with a mean arterial pressure of 45 to 55 millimeters of mercury, and ideally a systolic blood pressure of 50 to 70 millimeters of mercury. Pulmonary arterial pressure in patients with PPHN is at or near normal systemic levels, and this can be accomplished. Basically, our circulatory support can be accomplished by maintaining intravascular volume of fluids, and we can transfuse packed red blood cells to replace blood and to maintain hemoglobin concentration of more than 15 and a hematocrit percentage of 40 to 45. Inotropic agents can be used for circulatory support, but we need to, before the commencement of inotropes, we need to consider and treat the cause of hypertension or hemodynamic instability rather, and that can be hyperinflation, hypovolemia, or vasodilation. So in that case, we need to give fluids, and left or right ventricular dysfunction. So inotropic agents of choice can be dobutamine, which is an inodilator, and this will increase cardiac output and decrease pulmonary vascular resistance and systemic vascular resistance. Adrenaline which is an anaconstrictor. This will increase systemic vascular resistance more than pulmonary vascular resistance, and dopamine, which is most commonly used, which is an anaconstrictor. And if your echo demonstrates right or left ventricular function, IV molnupiravir in conjunction with inhaled nitric oxide may facilitate reduction in pulmonary vascular resistance while enhancing myocardial performance. So basically maintaining your cardiovascular stability. However, evidence of safety or efficacy of molnupiravir is lacking in neonatal PPHN, so we don't advocate for it. Surfactant is another choice of therapy. However, it doesn't appear to be effective in PPHN as the primary diagnosis. It can be considered, though, if patients have associated parenchymal lung disease, so basically secondary PPHN, so in patients with respiratory distress syndrome or meconium aspiration syndrome. Acidosis increases pulmonary vascular resistance, so as we've mentioned before, we need to maintain our PaCO2 between 40 and 50, and to improve metabolic acidosis by cautious correction of a severe base deficit. So in the event of a severe base deficit, sodium acetate is our choice of fluid rather than a rapid infusion of soda-bic, because this may worsen intracellular acidosis in this case and is not recommended. So in cases of severe persistent pulmonary hypertension, of those that fail to respond to supportive measures, so basically in infants with an oxygenation index of more than 25, and the oxygenation index is the FiO2 we're using. How we calculate oxygenation index is FiO2 times by the mean arterial pressure of ventilating patient gas divided by the partial pressure of oxygen. So if that is more than 25, despite the use of the oscillator, these patients are candidates for inhaled nitric oxide. And these agents, inhaled nitric oxide, will decrease your pulmonary vascular resistance, or they could be candidates for extracorporeal membrane oxygenation, so ECMO. And this provides adequate tissue oxygenation until your pulmonary vascular resistance drops. So inhaled nitric oxide improves oxygenation and reduces the need for ECMO in late preterm infants with severe PPHN. In a study done by the NICHD, they did a trial of 248 neonates with severe PPHN, so it's an OI of more than 25. The use of ECMO was lowered in patients who received inhaled nitric oxide compared with controls. And the oxygenation of these infants improved. Oxygenation improved in 50% of infants who received inhaled nitric oxide. The OI decreased by a mean value of 15.1 within half an hour to an hour after commencing inhaled nitric oxide therapy. And there's also a mean increase in the PaO2. So the mode of action of inhaled nitric oxide, this is a selective pulmonary vasodilator, and it decreases the pulmonary artery pressure and pulmonary to systemic arterial pressure ratio. In terms of how it is metabolized, it's rapidly inactivated in the blood into methemoglobin, inorganic nitrates, and nitrites, byproducts of the metabolism of inhaled nitric oxide. So we have absolute and relative contraindications to the use of inhaled nitric oxide. The absolute contraindications are duct-dependent lesions, congestive cardiac failure, as well as congenital abnormalities that are incompatible with life. The relative contraindications include uncontrolled bleeding and profound thrombocytopenia that doesn't respond to platelet transfusions. Just to note, inhaled nitric oxide does not appear to be of long-term benefit in patients with congenital diaphragmatic hernia. So in terms of administration of inhaled nitric oxide, the indications are in term or late preterm infants with severe hypoxemic respiratory failure, on conventional ventilation or on the oscillator. An echo diagnosis of PPHN must be confirmed in order to commence inhaled nitric oxide, and we have to exclude structural abnormalities of the heart. The initial dose that we use is so the initial dose of nitric oxide that we start at is 20 parts per million, and higher doses are not seen to be beneficial, and doses exceeding 40 parts per million are associated with hemoglobinemia. And in infants who don't respond, an improvement of approximately 20% in the PaO2 or saturation levels. Patients who respond, you'd see an improvement in approximately 20% in the PaO2 or saturation levels within 15 to 20 minutes of commencement of inhaled nitric oxide. So how we wean nitric oxide, we look at our FiO2 and our oxygenation index, and also there's no evidence of a dose-response relationship, so the dose should be reduced as early as possible to determine the minimum effective dose. So when the FiO2 is less than 60% or OI is less than 10, we can decrease the dose by 5 parts per million every 4 hours, so long as the OI remains less than 10. So when we get to a dose of 5 ppm, we can decrease by 1 part per million every 4 hours, and we stop at 1 part per million if the FiO2 is less than 60% and if your PaO2 is greater than 60. If we don't see a response within 30 minutes of commencement of inhaled nitric oxide, we need to stop it. And an inability to wean the FiO2 to less than 100% within the first 24 hours, as well as to wean the dose to less than 20 parts per million by 48 hours, associated with a high mortality. Adverse effects of inhaled nitric oxide. So you have methemoglobinemia, which has not been reported at a dose of 20 parts per million. We need to monitor your methemoglobin on blood gas, and we aim to keep the levels less than 2.5%. If the levels are more than 5%, we need to reduce and stop the inhaled nitric oxide. And if the levels are persistently above 7%, then you need to give methylene blue. Platelet dysfunction is also an adverse effect, as nitric oxide inhibits platelet function and causes prolonged bleeding time, and your nitric oxide accumulation, which can cause pulmonary injury related to increased levels of nitric oxide. So ideally, we need to keep nitric oxide levels less than 1.5 parts per million, and if the levels are greater than 2 parts per million, then we need to reduce or stop the inhaled nitric oxide. ECMO. Criteria for institution of ECMO or extracorporeal membrane oxygen include an elevated OI that is consistently greater than 40. However, because the mean arterial pressures are higher on the RC than on conventional ventilation, some clinicians will wait until the oxygenation index is greater than 60 when the RC is used. Most patients with severe PPHN are weaned from ECMO within 7 days. Sometimes more than 2 weeks may be necessary for adequate remodeling of the pulmonary circulation. Other options for vasodilation are sildenafil. So sildenafil is a phosphodiesterase 5 inhibitor and has been shown to selectively reduce pulmonary vascular resistance. You can give it IV or oral. The IV dose, we load with a dose of 0.4 milligrams per kilogram for 3 hours, and then we give a maintenance infusion. However, guidelines from the American Heart Association conclude that sildenafil may be a reasonable adjunctive therapy for patients with PPHN who are refractory to inhaled nitric oxide, keeping our pH more than 7.25 and the ideal pressures that we want on the conventional vent. Yes, and that is the end of my presentation. These are the references that I used. Most of my information was collected from articles found in PubMed as well as today. And thank you for watching and listening to my presentation. Don't forget to subscribe and turn on your notifications. Thank you.